Hi, good evening, everyone. I want to welcome everyone to Baltimore County Fire Department's EMS Academy. This evening's topic will be the neurobiology of trauma, and it's brought to us by Evelyn Kim. Evelyn is a retired nurse. She graduated from originally Villa Julie College with a Bachelor of Science degree in nursing. And then she began her career 24 years ago at the R. Adams Cowley Shock Trauma Center. Uh, but most of her career was spent working the night shifts in Baltimore City emergency rooms. Currently, she is certified as a pediatric and adolescent adult forensic nurse examiner. She's been working as a forensic nurse examiner since 2011. She teaches the forensic examination and evaluation of gunshot wounds, the neurobiology of trauma, forensic photography, injury interpretation, child physical abuse, and human sex trafficking. Evelyn is a member of the Child Abuse for Medical Professionals with the University of Maryland Hospital. She's a member of the Sexual Assault Response Team with Baltimore County, as a member of Human Trafficking Work Group. Evelyn is an expert witness in sexual assault for Baltimore County and Baltimore City. She's also an expert witness in the neurobiology of trauma for Frederick County. She has testified in over 11 trials during her career as a forensic nurse and was named Baltimore's Best Nurse in Baltimore Magazine in 2017. She received the Certificate of Excellence in 2020 and was awarded the Art of Nursing Nurses Clinician of the Year in 2022, and then retired in 2023. She is kind enough to join us this evening to give us her talk on the neurobiology of trauma. And again, I want to welcome her. So without further ado, I'll bring you Evelyn.
Hi, good evening. Thank you so much for having me as your guest speaker tonight. I will be talking to you about the neurobiology of trauma. And I'm going to just go over a few housekeeping things. I have no conflicts of interest, no personal, financial, professional relationships with organizations that will influence the information provided tonight. There is a trigger warning. Due to the sensitive nature of the topic, some portions of the presentation may be triggering. I will talk about several cases that I have had, and they're primarily sexual assault and also strangulation cases. Some of the stories you may hear might be disturbing. If you feel that you need to get up and walk away, we completely understand, and please do so. And also another warning as EMS, please do not interview victims of sexual assault. Do not interview children reporting sexual assault or children reporting sexual abuse. Only social workers that are specially trained as certified forensic interviewers they're the ones who interview children reporting child abuse or child sex abuse. Forensic nurses, detectives, and police never interview this type of crime either. We do not interview children, only the forensic interviewers. So my main objective today is, as a first responder to a sexual assault, a strangulation, a physical assault, or a mass casualty incident, such as a shooting or even a car accident, understanding how a victim will present on an emotional level and the ability to recall events is crucial in investigating events of a crime. You may be one of the first to have critical information to provide to law enforcement in maintaining the safety and security of their environment, such as even a school shooting. Understanding how the brain and how events can be permanently etched and will alter the human's response to stress. Assault. By definition, Merriam-Webster Dictionary, assault is a threat, or an attempt to inflict offensive physical contact or bodily harm on a person that puts the person in immediate danger or in apprehension. So I'm going to just kind of jump into the areas of the brain. The next few slides, they're red background slides. They are technical. They talk about the different areas of the brain and what those areas are responsible for under a traumatic event. So it's technical and it might be a little confusing, but then I'm going to circle back around to that information, and by the end of the presentation you will have a full understanding. But we just have to kind of muddle through the next few dry technical slides. So the frontal lobe is essentially the central operating system of your body. The frontal lobe is the illuminated area in the right side of the picture. That is the large area in the frontal portion of your head. That's the frontal lobe. The frontal lobe allows us to have rational thoughts. It provides judgment, self-control, social understanding, appropriate behavior, and interactions. The frontal lobe is responsible for memory storage, learning, and recall of that memory. Prevents us from doing irrational things, such as screaming and yelling, inappropriate language. However, there's another area of the brain, and that's called the amygdala. The amygdala is always on guard, scanning for threats, both inside of your body and also externally in your environment. Normal functioning frontal lobe during a calm and restful state, such as here and now, the frontal lobe maintains your focus and attention. It aids in making logical decisions, displaying rational behavior, is responsible for speech and language ability, responsible for our personality, allows us to perform multi-step tasks, such as driving a car and making coffee. The frontal lobe also stores memories in a narrative form. If I asked you to recall the events of your day, you would be able to give me a narrative pretty much based on a timeline of events. The frontal lobe is the last area, the part of the brain to develop, and generally doesn't develop until the age of 22 to 24, which is why teenagers do things that made not logical, poor decisions, not always the best idea teenagers do. It's because their frontal lobe is not developed until the early ages of 20. Now, alcohol will impair the frontal lobe and all of the above functions: speech, memory, walking, talking, problem solving, and multi-step tasks. So the brain does not protect us from stupidity, but instead from bodily harm and death. So I'm going to talk about from the frontal lobe to the limbic system. And these are the areas of the body that react under stress. So essentially the day in the life of a trauma, the brain is in a calm and restful state, functioning by the frontal lobe. You freeze for a second. You're startled by the feeling something's wrong. You realize you're under threat. Someone will be harmed or possibly die. The trauma stress response is activated. The frontal lobe shuts down. Stress hormones flood your body. At the height where you feel the most fear, formation of a deep ingrained memory of the traumatic event occurs. The day is no longer a neat timeline of events, but detailed fragments with black holes of memory. So the amygdala is so you have the frontal lobe, which we talked about. Another area of the brain is called the amygdala. The amygdala, which is it's kind of like the fire alarm of your brain. It's always on, sensing for threat. You sense that you're under threat or trauma or something bad's going to happen. You freeze for a second. Your brain is trying to identify, is there a threat? Is the threat gone? Is there no threat at all? Once your brain realizes you are under attack, there is a threat. Again, the frontal lobe shuts down. So all of your memory formation in a nice, neat timeline, time, for example, the formation, the ability to speak and form words and proper sentences, all that shut down. The ability to do a multitask thing, even, walking or running, is shut down, and you're not able to do that when the frontal lobe shuts down. So these hormones flood the frontal cortex. The amygdala signals another area of the brain called the hippocampus. The hippocampus, its job is to superencode the memory of that time. So it starts collecting all of this information at that second, and it's only seconds, and then it stops. but the hippocampus is taking in all of this information, and generally it's sensory information. So it's going, well, I'm going to talk about that a little bit later. I don't want to get too fast. So the amygdala signals the hippocampus. You have super encoding, the memory ingrained occurs. Then you act. You either fight, you flight, so you flee and you run. You have tonic immobility, or you disassociate completely. So tonic immobility is the natural state of paralysis. You're unable to move. You are aware of what's going on. You know what's going on. You're trying to tell yourself to move or to do an act, to do something, to fight or run or scream. You're frozen in fear. You cannot move. Disassociation is when you are really not mentally paying attention to what's going on. You may be focused on, say, if it's someone, just say someone's being sexually assaulted in the living room, that victim may be focused on a coffee table in the living room, and all of their focus is on that item. So any questions that you're going to be asking is going to be surrounded by what they were looking, that coffee table that they were looking at, because that's where the memory is going to be. I think that's probably a little confusing right now, but it's going to make sense a little bit later. So habits and reflexes are extremely important and in traumatic and stressful events. So EMS, ER nurses, police officers are able to react calmly and in a controlled, chaotic environment, because you have the training. So your body is adjusted to, okay, I see multiple cars crashed, there's multiple victims. That's in your comfort zone because you're trained for that. Someone who is not trained for that, that can be a very stressful event for them. But through habits and training will also dictate how well someone, the body will get through. But that's how EMS and first responders and military police get through traumatic, how you're trained to do it. So the limbic system, which the amygdala falls under the limbic system. So this is basically the fire alarm in your brain. So, and I know I talked about this a little bit more. I'm going to talk about the amygdala a little bit more in depth. So if you see the picture at the bottom, the limbic system. So you have the thalamus, you have the amygdala, you have the hippocampus, and you have the hypothalamus. And we're going to be talking about those areas. So the thalamus is always pretty much on sensing, what's going on if there's a threat in your body or outside. When the thalamus detects that there is a problem, then it alerts the amygdala, and the amygdala is always on also for threat. So the amygdala collects the sensory information, processing fear and anger. If a threat is detected, then the amygdala activates the stress response. So the amygdala is known for the response to fear, but is also involved in the formation of positive memories. So memory is formed through positive or negative emotions, but memory is formed by emotion. You probably don't have a really great memory of the few times or many times that you went to the grocery store last month, because it's not anything that would be stored in memory, because it's not a very emotional thing to do to go to the grocery store. But if you went out with, I don't know, a special dinner with your family and you were celebrating something that would be a positive emotion and a positive memory, and you're going to be more likely to remember that. So memory is formed through either positive or negative emotions. So the limbic system, the hippocampus. So again, we're still in the limbic system. And just to kind of reiterate, the amygdala signals the threat. Then the amygdala activates the hippocampus. So the hippocampus is the information collector. They convert sensory information, and sensory information is if you smell something, if you had you feel something, there's a sensation. What did you taste? What did you feel? What did you see? What did you hear? All of it probes the sensory area of your brain into memories. So the hippocampus retains memories and converts short-term memories into long-term memories. So once the amygdala alerts the hippocampus is taking on sensory information and creating memories of that sensory information. The hippocampus then activates the hypothalamus, which alerts the pituitary gland. And that's another system that's activated, which I'm going to talk about too. So I'm going to just kind of slow down a little bit because I think I've thrown a lot of information to you right now. So memory that has fear attached is more likely to be remembered. Sleep is critical in converting that memory from long-term memory into a permanent memory storage. It's also called potentiation. Emotions caused by long-term memories will influence behavior, guiding someone's response to an emotional situation later in life. So an example, if a parent is screaming and yelling at a child and they freeze as a child, then say when they're an adult and they're in an abusive situation and they have a spouse screaming and yelling at them, they're going to freeze as an adult. Or if they're in a sexual assault or another type of trauma, they're going to tend to freeze. If that child was always fighting back for themselves, then as an adult, the first line of response is going to fight. So under stress, you're going to fight, flight, you're going to run away, or you're going to freeze. And the behaviors, past behaviors will influence future behaviors. So I have lots of examples, which we'll get into. And actually, I can't, we'll move on. So the limbic system, continuing on with the hypothalamus, is the expression of emotion, negative or positive, pain or pleasure. So, excuse me. So I thought that this was interesting for me to learn. I thought this was very, very interesting. So the hypothalamus, the expression of emotion, negative or positive, pain or pleasure. So the hypothalamus releases hormones in the bloodstream based on emotions. Again, memory is based on an emotional attachment. Some parts of the hypothalamus are associated with pleasure. The emotion of love and happiness triggers the release of dopamine, which is the feel-good, it's a reward system for your body. Oxytocin is the love hormone, promoting feelings of calmness, social bonding, and trust, which is why when you first meet someone and you're in a new relationship, it feels so good and so overwhelming. Well, I guess the oxytocin levels out after a while, and it's still fine, but it doesn't feel all that good and overwhelming anymore. But it's still a good relationship. But it's that oxytocin that makes that high for a new relationship. Now, some parts of the hypothalamus are associated with negative emotions. The sympathetic nervous system, again, triggers the fight, flight, or freeze. Childhood neglect causes a decrease in oxytocin levels, causing an increase in stress hormones, influencing a child's ability to cope with stress, causing anxiety, depression, and anger leading to violence. So what kind of sparked my thought on that is that when you see these children in school, and they're, especially when I was working as a forensic nurse, and we were doing a lot of like child abuse stuff and working more with children of child abuse and children who had like dysregulation problems with their emotion, that childhood neglect really impacts this child as they grow up and as they become an adult. So again, they have decreased oxytocin levels. So which means they have decreased hormones of feeling calm, social bonding, and trust. So with the decrease of the oxytocin level, they have decreased trust in society. They're not able to bond to people as well. They lack bonding, and they're not as calm, and more, again, causing anxiety, depression, and anger leading to violence. So I thought that that was very interesting, that, you know, behavioral later in life is very directly related to trauma, number one, and the hormones involved with that. I thought it was interesting. All right, so then we get into the HP axis. I told you this is really technical and it's kind of dry, but so the hypothalamus, so let me back up a little bit. So the brain's response to stress
We have a
affects
question for you.
Sure.
The question is, does the decrease in oxytocin last into adulthood?
From what from my impression, that it seemed to be. So let me go back to that slide. Childhood neglect causes decreased oxytocin levels, causing an increase in the stress hormones. So influencing. So yes, that was my understanding. Is that?
You might wonder if some of the anti-psych drugs or like the SSRIs or something might instead some way to increase the release of oxytocin as a therapeutic.
Yes. Yes. Because when you look at dopamine, alcohol and nicotine release dopamine, which is what draws people to have, you know, enjoy a drink or two. So same thing. So it would be interesting maybe to do more research into that. But I thought it was all very interesting when you really kind of pull it apart and look at it. So are we good? Okay. So the HP axis, so that's the hypothalamus, the pituitary gland, and the adrenal glands. So we're going from, you know, everything was the areas in the brain are activated. So now the area of the brain, the hypothalamus, then, triggers the pituitary in the brain. Then the pituitary glands activate the adrenal glands, and then the adrenal glands release adrenaline. Then you have your cortisol and epinephrine and no, one more epi too. I guess adrenaline, maybe that's what I keep thinking of. So anyway, so you have this release of adrenaline. So now you have a whole systemic response to stress or trauma. So the hormones related during a trauma. So you have the catecholamines, that's adrenaline. That's going to help with fight or flight. And that's going to give you more energy as well. So the cortisol affects the energy of the body, and that gives you more energy also for fight or flight. Opiates is the body's natural morphine, so that will combat any physical pain. and it could tie it to freeze. And then the oxytocin provides the positive feelings, makes you feel good. You might be involved in a pretty traumatic situation, but you feeling kind of elated, and you're seeming a little immune to what's going on. So one example, probably the best example in 12 years of being a forensic nurse, I had a patient, and she was a victim of a home invasion, and some of her roommates were there as well. It was the middle of the night, probably about 3 in the morning. Someone broke into their home, and he raped one of the girls, and then he went into another room and he raped one of the girls, and then one of the roommates got up and realized that there was an intruder, and he was going room to room, and he ran out. The 2 girls, police were called, special victims unit were called, detectives were on scene, involved right away. The 2 girls were brought to GBMC. I was called in as the forensic nurse, and the one patient, I went in to talk to her, and she was hysterical, crying hysterically. And then the other girl, her roommate, I went in to talk to her and to explain why I was there, and that I was there, called in by detectives to do a sexual assault forensic exam on her. But before I started talking to her, when I first walked into the room, she's sitting laughing hysterically on the stretcher, making jokes with the police officer at the bedside. It was they're just making jokes and laughing and stuff. And I had never really seen that before, and I was really quite surprised. For a second, I thought maybe I was in the wrong room. So she's, and then you look about, the oxytocin levels. She must have had, pretty elevated oxytocin levels, because she was having this feeling of elation. Then she stopped talking, stopped laughing, and was just muted in her demeanor. Then once I started talking about why she was there, that I was called in to do a sexual assault forensic exam, the pendulum shifted, and she was absolutely out of control, hysterical. And I had her for, I guess I took care of her maybe 4 or 5 hours. That entire time, she ranged from laughing hysterically to nothing, to crying hysterically, and back and forth within seconds. And that's a brain on trauma. She had so many chemicals going in her brain, in her body, that she just had no control over what her emotion is going to be. There is no set picture of what someone's going to present after. And we'll maybe stick with just primarily sexual assault and strangulation. But if you have a patient who's sexually assaulted or strangled, there is no typical presentation that they're going to have. They can have any range of emotion. So here's a video, and this is just going to kind of sum everything up that I just talked about. And then I'm going to get into some of the cases that I had and kind of pull things apart a little bit more. And then if you want to, after the video, want to chime in, or, even talk about some of the cases that you had, feel free to. So I'm going to go ahead and play this. Whoopsies. No. Hold on.
We need to take a statement so we can establish what happened on Saturday night.
What time did you get back to David's flat? What time? I don't know.
Can you give us an estimate?
I don't remember.
Would your pals remember what time you left the club?
He seemed nice.
She didn't remember much, did she?
I know. And now we've got to waste more time on a daft lecture. We know how to deal with victims. We've had years of experience.
Well, some of us have had more years than others.
I'm in my prime, I'll have you know.
That'll be right.
Today's session is about trauma. The latest in brain science will help you in your work. I'll start with a tour of the parts of the human brain. The reptilian brain maintains basic bodily functions. The limbic system is also instinctive. It deals with fear and pleasure. For example, you pat a dog, it senses pleasure, and without thinking, wags its tail. The neocortex is the site of logic, imagination, planning, and control. It's more sophisticated, but because it's conscious, it's slower than the older parts of the brain. The amygdala is a key part of the limbic system. It has one job: to sense danger and set off the alarm. When it's a matter of survival, the primitive parts of the brain override the conscious part. There are 3 possible survival responses: fight, flight, or the one that people don't think of, freeze. When the alarm goes off, blood and oxygen are diverted to muscles, adrenaline floods the body, and all systems that are not crucial to survival are switched off. Normally, the job of the hippocampus is to file memories so you can retrieve them later, but in times of danger, it stops filing memories, which makes it harder to gather evidence later on. Instead, the hippocampus switches to pumping cortisol. What's useful about cortisol is it stops us feeling pain, so we can focus on survival. Can anyone give me an example?
A farming accident where a man carried his own arm for a mile without feeling any pain?
Yes, excellent example. It is an evolutionary safety mechanism which is fast and instinctive. In essence, it's our body's very clever way of protecting us. To recap, an example of the 3 parts of the brain working together. You're standing at a bar. Your reptilian brain is keeping your heart beating. You're enjoying the pleasure of a nice pint with your limbic system. You're using your neocortex to work out if there's time for another before the last train. What could happen to make the amygdala kick in? What if this happened? The way you'd respond would depend not on your logical brain, but on your instinctive brain. Being glassed in a bar would be a traumatic experience. Who can give me another example of an event that can cause trauma?
War?
Rape?
A car crash?
Good, yes. Trauma occurs when a person is overwhelmed by something beyond their control. The survival brain takes over the rational brain. It can lead to post-traumatic stress disorder, PTSD, with symptoms that last at least a month. Vicarious or secondary trauma is something you may experience if you deal with incidents such as rape or sudden death, or think of Lockerbie, Dunblane. You're not superheroes. Having a brain makes you all vulnerable to secondary trauma. It's important to understand that when trauma occurs again and again, it can become complex PTSD, such as in domestic abuse or child sexual abuse. The alarm system in the brain becomes jammed. Memories are stuck in the limbic system, so a trigger can set off the alarm. The trigger could be anything: a colour, a smell, a sound, a sensation. Now, the indicators of trauma. What should you be looking out for?
Depression. Crying a lot?
Yes, that's one response. And at the other end of the spectrum, total numbness.
Nightmares? Flashbacks?
Stress.
Good, yes. And they may feel sick. Also, shame, feelings of guilt, inability to enjoy sex, social isolation, triggers. People often feel overwhelmed by the symptoms of trauma. This can lead to using alcohol or other drugs to block out memories, or self-harm, or dissociation when a person's mind detaches from reality. Indicators can be specific to the type of trauma. Say, dental problems, when someone who was orally abused avoids going to the dentist. A victim of abuse might bond strongly to her abuser. This is known as traumatic bonding, or Stockholm syndrome. And jumbled up memory, when a person's normal recording of memories doesn't work. Can you recall any times you've seen that symptom?
What time? I don't know.
A traumatised person may not seem like her usual self, or may be hypervigilant, on edge, or being startled by everyday things. Everyone is different. You never know what impact trauma will have. Symptoms can change from day to day. So what does all this mean, in practice, in your job? A traumatised person's brain is protecting them, but that normal human response of self-protection can get in the way of evidence gathering. The US military has developed new trauma-informed interviewing techniques that you can use to work around this. Research shows that if someone seems vacant, they could be distracted by their traumatic memories. Try to ground them by asking a simple, non-patronising question such as, "Are you thirsty? Do you want a glass of water?" This can help bring them back to the here and now. Don't expect a logical, linear story. Ask, "What can you recall just now?" Find out what the victim physically felt or saw. Working this way, from the instinctive sensory parts towards the logical parts of the brain, you'll get more results. In conclusion, 4 things for you to take away. Trauma response is the brain in survival mode. Repeated abuse can make trauma symptoms worse. In response to trauma, people will behave in unexpected ways. Remember, trauma is a normal human response to abnormal events.
We know that you've gone through a really painful experience, but we need to take a statement to understand what happened on Saturday night.
Are you able to tell us anything that you remember about his flat? Anything at all?
A dog. Barking.
Are you able to remember any physical sensations or feelings that you had?
Cigarette smoke. I can smell it now.
What was going through your mind?
I couldn't understand it. I just couldn't move, or even scream.
To freeze is a perfectly normal response. So you start with the memories, you don't start at the beginning. You have to engage with feelings to get to the facts.
Makes sense. Check you, Professor, getting all sciencey on us.
Well, if it gets us usable evidence.
There's life in the old dog yet.
Oi.
There we go. No, all right. So, let me back up a little bit. So I hope that that kind of clarifies things a little bit. And then we're going to move on. So I do have a presentation, like a case study, and I have several. So what's important is that for the frontal lobe, that under normal, calm, restful state, you're going to have the recollection of events in a nice timeline. And then I'll talk about peripheral details and central details, but peripheral details under a normal restful state is going to be like maybe the color of the walls in a room, the color of the curtains, more, we'll get into that a little bit more, but then in trauma, the area of the brain, the hippocampus, the memory is stored in that area, and it's based on sensory information. What did you see? What did you smell? What did you hear? So I'm going to go ahead and get into, here's a case study. He choked me again. I thought I was going to die. So this patient, I asked her, please tell me what happened, or what are you able to tell me happened? And her first statement, and let me back up for 1 second. If you have a victim of sexual assault or strangulation, domestic violence abuse, write down word for word what they say. It's probably not going to make a lot of sense. It's not going to be in a neat timeline of events, but writing down word for word what they say helps prosecutors look at that too, and even forensic nurses look at that. And then once I point everything out to you, you can clearly see that that brain is on trauma, and that's a traumatic response. And once I point it out, you'll be able to see that as well. The first few sentences that that patient tells you of that traumatic event is going to be the moment where they felt fear the most. So in any trauma, you're going to have a beginning of the day when everything is normal and fine and things are in a nice timeline of event. Then you're going to have that traumatic situation. And then you're going to have the aftermath of that traumatic situation. When someone is thinking of remembering the events of a trauma, and we all can think of, something that was scary or traumatic or whatever, your brain goes directly to the area, or a victim's brain is going to go to the moment where they felt fear the most. And then there may be like a blank spot in their memory that they have no memory of for a little bit. And then they'll have another memory where they felt fear again. And that's why memory is fragmented, but what is remembered is very clear and never goes away. So the case study, her first statement, he was choking me. I couldn't breathe. I don't know what happened. That was her first statement to me. She had a flat affect, absolutely no emotion, no tears. Her energy was drained from the release of the stress hormones. So then I asked her, okay, tell me about the day, like wherever you want to start. So she started, we woke up around 1 or 2. That's a timeline. 4 p.m., another timeline. Me and my husband were arguing. I don't know what we were arguing about. He took my keys, phone, and wallet. The timeline stopped in her brain when the argument began. So as soon as he started arguing with her, you can tell at that moment, she knew there was something wrong. Her brain switched on. Her brain knew trauma is coming. This is going to be a stressful event. Finding out later, when they would argue, he would strangle her. He strangled her in the past. So when I was looking at this narrative and writing it up, I thought it was very interesting. We have a timeline of 1 to 2 p.m. We have a timeline of 4 p.m. As soon as he started that argument, the timeline stopped. Her brain was shutting down. Her stress hormones were taking over. Her frontal lobe was diminishing in processing. Then the rest of the timeline, or the rest of the report. I left and started walking. He followed me. He started yelling and arguing with me. So I turned around and walked home. He was arguing with a man. I went home. He came in. He went outside to look for my phone. He came in the back door. He kept pushing me. I fell into the couch a couple times. I went into the kitchen. We were in the kitchen. He choked me and I couldn't breathe. He choked me again and I thought I was going to die. It was much harder. I remember I was on the floor. I woke up and I don't remember anything. She reported her body feeling very heavy. She's probably had lost consciousness at that point. But if you look at this, simple terms, she's not able to give me full, complete, eloquent sentences. Her brain is limited in language ability. There is no timeline. This is it's very jagged. It's very confusing. I don't know what room they were in during what episode. Did everything happen in the kitchen? I don't know. And that's why it's important just to write down verbatim of what they're saying. All of that will come out later in investigation by police. The other most important thing is that when you have a victim of a crime, especially a sexual assault, sexual assaults are the most difficult crime to investigate because often they're hard to prove, and sometimes it's one person says against the other person, and it's hard to prove. And I'm going to talk about the suspect's brain and the victim's brain a little bit later, and that kind of explains also furthermore why they're difficult. But staying on focus with this, these are difficult crimes, but how well the victim recovers from the crime of sexual assault or domestic violence, especially sexual assault, how well a victim will recover from that crime depends on the first interaction of EMS, of police, and the very first interaction when they get into the hospital. If they're doubted by EMS, if their story is doubted by police, chances are they're going to carry that doubt into the hospital, into the forensic exam, thinking, well, they didn't believe me. Why should you believe me? Things unravel, and chances are those victims do not recover. They never become survivors. They don't do well. So you set the stage as to these victims becoming survivors. So still with the same case study, he choked me again. I thought I was going to die. So I asked for clarification of details. Can you tell me more? What are you able to tell me? Then she proceeded to say, my son came in the kitchen. My son came in the kitchen and pulled him away in the kitchen. I went in the living room, couldn't breathe and hyperventilating. My other son called police. He came in the living room yelling at my face, straddled my legs, bit me twice in the head, then face. My first thought is, there's two sons in the home, witnessed this, and you didn't mention it. The reason why she didn't mention it is because in her brain's on trauma, her frontal lobe is shut down, all the hormones have taken over, her hippocampus is storing as much information. She is on like fight, flight, or freeze mode. And I think she was trying to fight. And the reason why she didn't mention the sons is because in her brain is protecting her from death and from harm. Her brain knew her sons were not going to harm her. They were not a threat to her. So they're not really important, and they're not going to come out initially the first thing in the story. She's not thinking of an alibi or to have witnesses. That's not her thought. That's a higher level of functioning if you're thinking that. She's not thinking of witnesses to this assault. She's thinking survival. She wants to live through this assault. So her sons are basically a peripheral detail. They're not significant to whether she lives or dies, even though, yes, they're probably going to fight for her. But in her brain, they're not going to harm her. So they're not. So this is why they kind of came in later on the investigation. Now, then I spoke to the police officer who brought her in, and the patient was upstairs when patrol arrived. She came downstairs and said, he choked me. So now when someone does say he choked me, put choked in quotes, and then you do document strangulation in your report. Just a caveat to strangulation. So the bruise and the bite mark was visible, and there was a small bruise on her neck. She did not mention being bit, and chances are she might have just not had that memory of that. If her brain was taking in pictures of memory and then having periods of where her memory is black and she has no, he could have bit her in one of those areas, or she could have been unconscious. She also reported that the force was greater in the kitchen than the choking in the living room. So, but you had just a very blunted, brief narrative and not very detailed. So when there's fear, there's what's called superencoding. So the memory kicks into high gear, takes in as much information, and chances are, generally, it's sensory information, and you have a solid memory formed at that moment in time. Everything the victim is paying attention to gets encoded in memory, but it's what they have to have their focus on. So if they're not focusing on peripheral details, what time it is, what color are the curtains on the wall, that's not going to be put into memory. So the questions of who, what, where, why, how, they're poor questions, because those questions in an assault, those questions are probing to the frontal lobe. Well, the frontal lobe is shut down. So any of those questions, they're not going to know. So the answers are going to be, I don't know. Who all was there? Who else was in the room? I don't know, because that's a frontal lobe. That's a higher level of reasoning, thinking, area of the brain that you're just not going to have that answer to. What time was it? Well, the frontal lobe is shut down again, and the hippocampus doesn't care what time it is, because the time doesn't, time stops. When you're in a traumatic event, time stops. So what time was it? How long did the assault last? Not a good question either. Time stops. So all those questions, if police are asking a victim of sexual assault and they're saying, I don't know, then their story is going to be doubted. Or if you're asking these questions, well, what time did it happen? I don't know. How long did the assault last? I don't know. Was there anyone else there in the background? I don't know. Then the assumptions are this never happened, because they don't know. How do they not know? Because the area of the brain of the line of questioning that is being asked was deactivated at that time, and the questions are simply not there. So trauma memory is permanently etched in the brain. Trauma memory is the memory stored in the hippocampus based on sensory details. What did you smell? What did you hear? What did you see? What did you taste? Also, what did you think was going to happen? When someone says, I will never forget that moment, that's where, for law enforcement, I've taught this at the FBI, and for the forensic nurses, when someone says, I'll never forget that moment, that second during that, that's where the memory of the events is locked. And that's where the line of questioning needs to come in. For example, I had a patient, she might have been abducted, taken to an apartment. She didn't know the person. She didn't know the apartment. Long story, police, she called police. She was sexually assaulted. She called police, and detectives interviewed her. They figured out where the location was that she was taken to. They believed her story completely, so they didn't doubt her story. But every question they asked her, she said, I don't know. Where was this? I don't know. What was the layout of the room? I don't know. Every question they asked. So they called me and they said, if you could just collect forensic evidence where you think the best chance of collecting evidence would be. And sometimes when we don't know where to collect evidence, you really just take a shot and kind of think where the best evidence. So, you swab the mouth, the neck, the breast, genitals and stuff. So I asked her, a few questions like, what can you tell me happened? I don't remember. Do you remember what he looked like, about how old he was? I don't remember. She had absolutely no memory of this event, this assault. So then, thinking of neurobiology of trauma, I said, do you remember seeing anything? What did you see when you went into his apartment? And she remembers seeing a dog crate. There was a dog crate. Did you hear a dog? Did you see a dog? No, she didn't see a dog. And then I said, what did you hear? Could you hear any sounds, like outside of the apartment or in the apartment? Any sounds, a television, people talking, anything? No. No sounds. The last question I asked her was, what did you smell? Did you smell anything? Do you remember smelling anything? And she paused and looked up, staring at the ceiling, and was like, oh my God, Jergens lotion. I remember smelling Jergens lotion. In the hippocampus, under smell, was Jergens lotion. That's where that memory was locked. So you have to figure out, where's that memory locked? How do I get that key in there, unlock that memory? Then she was like, the room was set up, the bed's here, the dresser's there, the side table's there. He opened the drawer, he pulled out the Jergens lotion, and then she proceeded to give me every single detail of that sexual assault. Based on that memory was locked in the primitive area of her brain under the sensation of smell, the sensory area of smell. I called detectives, said, are you still on location? Is crime lab there? Get the Jergens lotion. And then I was able to document in my report for the crime lab that swabs possible for Jergens lotion, I feel was used during the assault. But I was able to call detectives and say, hey, this is the layout of the room of what she's telling me. Does the room look like this? Is this here, this dresser, this side table, the comforter, the Jergens lotion? And the Jergens lotion was still sitting there. And they had no idea that that was a factor, a major factor in the sexual assault. And it was just the line of questions. And that I thought was absolutely amazing. So let's see what else we have. So I keep talking about peripheral and central details. So peripheral details, again, they don't make strong memories. The information is not important for survival. And, when I started years ago, detectives, before neurobiology of trauma was a thing, you'd hear, detectives, what color shirt were they wearing? And sometimes even on TV, I hear it, I roll my eyes, like, terrible question. What color shirt were they wearing? What time was it? What was the room layout? What was the car make and model? What was the car color? And the other thing, so, if police are asking these questions, or say EMS, you're asking these questions, and every answer is, I don't know, I don't know, I don't know. There's some doubt that, did this crime really happen? Don't doubt, it most likely did. And actually, in a red flag is because a few sexual assaults, for various odd reasons, people would make up sexual assault and come in with this glorified story. And I always knew it was a made up sexual assault when it was, oh, well, I remember every detail. He had a red shirt and he was driving a blue car and the make and model and all these details. And then it's like, and then you generally know that the story is fabricated. And, we did have a few people that would come in frequently and make up sexual assault. It's not often, so I don't want you to think that take them all seriously. Let law enforcement and investigation rule them out as false reporting, but 100% take every single one seriously. But I'm just saying that when someone came in with overly amounts of detailed information, especially peripheral details, you can kind of tell that they're not exactly truthful. And that's with like assaults and murders too, when the suspect has these unusual amounts of peripheral information. It's like, okay. Because peripheral details are really more stored in the frontal lobe of the brain, which is higher level of functioning intelligence. So central details, they create a strong memory. Their central details are associated when the amygdala senses fear. The hippocampus is activated, central details get locked in that hippocampus, just like the Jergens lotion did. Sensory memories can be a smell, a look on someone's face, the sensation of being held at the neck or wrist. The patient says, "I'll never forget again." That's when fear took over and superencoding of central details and some peripheral details began. So pertaining to central details, the sensation. When I was working as a forensic nurse, I noticed that when someone came in who was strangled, they would tend to be touching their neck and stroking their neck. And it was interesting to me because their brain, the primitive area of the brain, has stored that sensation of being held at the neck. The other thing is that I had a patient who, he was again a victim of a home invasion during the day, supposed to be in high school, stayed home from school, and he was tied up. He was beaten and he was tied up. And when he came in, I was just asking him different questions about the assault and who it was and just details of the assault. And he never mentioned that he was tied up and that his wrist hurt. But I noticed that he kept drawing on his wrist and just kind of feeling on his wrist and rubbing his wrist. And then I asked him, "What can you tell me about your wrist?" And he said, "Oh, I was tied. I was bound and tied up. And what did they use? A cord." And then once I started looking at his wrist, I could see the deep furrows in his wrist from a cord. I would have gotten to that eventually on my physical exam. But it was interesting because what drew my attention to his wrist in the first place is where he was touching. So when you have a patient who's sexually assaulted or domestic violence, and if they're kind of stroking one area or touching an area, just ask them, what can you tell me about your wrist? Or if they're touching your neck, what are you remembering about your neck? Or what are you feeling about your neck? What are your thoughts? Or do you still feel the sensation of them holding your neck? So it's just interesting that these are the memories that are ingrained and that they never seem to go away. And if someone doesn't realize that, like for the Jergens lotion, if I wasn't able to pull that memory out and really pull that to the forefront, and then we could realize, wow, that's where the whole crime is locked in under that memory, then that person, every time they smelled Jergens lotion, it would have been bells and sirens going off in their head of trauma. And so hopefully that kind of helps through that process as well. All right, so here's another case study. This is disturbing. So you know, if you just have to walk away from any of this, or if you just need a minute, it's fine. Please take a minute. So this, and I know you're all EMS, but it's still, we're all still human. So this case study, I call this hanging in the shower. And I asked the girl, please, can you tell me, what are you able to tell me has happened? And generally, if you word it, what are you able to tell me? Then whatever their answer is acceptable. As opposed to, give me the who, what, where, why, and how. Just the facts. Give me just the facts. Then they're not able to give you the facts. And that's, you know, just harmful for their healing. So, excuse me. So, can you tell me what happened? She said, I was face down. He tied my hands behind my back, the broomstick, a belt tied around my neck. He dragged me into the bathroom. He cut me. I tried to block it. I was cut. He stood me up and pulled it tight on a shower curtain rod. I struggled. My toes were on the tub, feet off the ground. He sat there watching me struggle, laughing. I got the belt off my neck. He kept beating me on my forehead with the window screen. I tried to jump out the window. He kept dragging me in. This is jagged, blunted story. Again, use of simple terms, lack of a timeline, lack of detail, confusing, unorganized, flat affect, like she's giving me a list for the grocery store. No emotion, no energy. The brain on trauma can look like lies. But once you understand how the hormones take over, how the frontal lobe is suppressed, how the primitive area of the brain is activated, this is what a brain on trauma looks like. So let's delve a little bit deeper into this case. And I want you to think, okay, so she was cut. What does that mean? He cut me. Just think in your mind, what does that mean to you? He cut me. Little cut. How long do you think this assault lasted? A minute? 5 minutes? 30 minutes? 3 hours? Not sure, but we'll find out. So I asked for some of the statements to be clarified. And I did this very slowly. And I would break up the clarifying questions with questions to bring her back down to reground her. Are you thirsty? Can I get you something to drink? Do you need a break? Do you need a bathroom break? Do you have any pets at home? Sometimes I incorporate a very simple line of questions to kind of bring their stress hormones down. If a victim of crime is being questioned and interviewed by forensic nurse, by you, by EMS, you need to get the information, by police, and we're bombarding them with questions and we're increasing their stress levels again. Guess what? Their frontal lobe is shutting back down and you're not going to get the information. So you do want to make sure that your patient knows they're in a calm controlled environment. You're there to take care of them. They're not in harm anymore. You're going to take care of them, and you believe them. And so during her clarifying statements, I said, you were face down. Your hands were tied behind your back. What were you referring to? Can you tell me more about that? And then she said that that's when she was sexually assaulted, and she was assaulted with an object that she had mentioned. And then I said, you mentioned a belt was around your neck and secured through a silver part. And then once she was calm and her frontal lobe started, being able to recite things and in a better language skills, she's like a belt buckle. It was a buckle. But initially, she could not even remember the term buckle. It was a silver piece. He punched her in the face, knocking her unconscious in order to hang her body. He put the end of the belt over the shower curtain, pulled her body up in a hang position. She regained consciousness, and she was hanging from the shower, and he was watching her, laughing, waiting for her to die. So at first she stated that her feet were off the ground. Then she stated my toes were touching the top of the tub. So, and it was probably both, a variation of both. But just because she changed that statement doesn't mean that she was being deceptive. When I asked, okay, you tried to jump out of a window, which window? The second story window. She tried to jump out because her brain is telling her, primitive brain is saying, you are safer jumping out a second story window than you are staying here. If you stay here, he's going to kill you. But if you jump out the window, you might survive. This is why people jump out of windows in fires at 9/11. That's why so many people jumped out of windows, because their primitive brain was saying, you're going to die here. You have better survival jumping. And that's tragically sad. And then I asked her, what can't you forget about the assault? What can you not forget about the assault? So basically, when you think of the assault, where does your brain go? She said, the belt around my neck and him slashing me with a knife. This assault, and she endured 5 hours of assault. But her strongest memory is when she felt the most fear. So let's get into her injuries. So the assault lasted 5 hours. I did a head-to-toe physical exam. She had a defense wound, an 18-centimeter laceration, 18-centimeter running from her elbow to her wrist. She received 14 stitches. She was protecting her face from the knife, which the butcher knife then went into the door. Then I examined the inside of her mouth. She had absolutely no trauma to her face whatsoever. I looked in her mouth. She had a broken front tooth. She had lacerations, bruising in her mouth. The ligature marks were visible on her neck. She had bruising to her left chest and her left arm. Once I asked her, tell me about the bruising, tell me what happened. And then she remembered that at some point during the assault, he was stomping her on the ground. She had a nasal deformity, swelling and bruising and pain. So we had x-rays done. She had a broken nose. The body cam review by the officer revealed that she vaguely mentioned sexual assault. The police officer called her at home and said, I'm going to come and pick you up, and I need to take you to GBMC for a sexual assault forensic exam, which is how then I was called in. She was taken to another hospital by EMS. She was sutured and released. Released with a broken tooth, released with a broken nose, released with chest contusions, released as sexual assault and strangulation. None of it was assessed. Just her arm sutured. So that was that. He was arrested, obviously. So we're going to talk a little bit about the difference between a suspect's brain and a victim's brain. And there's one case in particular, all the cases, this applies to most of the cases. There was one case that it was he was a serial rapist. He had just been let out of prison a few months prior to he did this crime, and he selected an area where he was going to go. His victim basically was the next person who walked out of that building was going to be his victim. He had, a week prior, he had done the route from his house on the bus lines out to the county, walked the area to where he was going to commit the crime. Then we'll just say it was a shopping center. It wasn't, but we'll say it was a shopping center. Just to protect the patient's information. If I said where it was, you'd look it up and you know where it is, but to protect her privacy. So he went to the shopping center and then timed, knew every aspect about that area, had it all down, knew where he was going to hide, got back on, walked back to the bus, took the bus back to his home, which was like Ricerstown Road and Northern Parkway area. So, and police had that on his phone, GPS phone. They could ping him to tower to tower. So during trial that came out. So the suspect, he had a bag, he had gloves, he had cord, he had his phone with him. He turned his phone off when he got to the shopping center. He had the maps of the bus transit. He knew which buses to take. When you look at suspects when they're carrying out a crime, they're using their frontal lobe to carry out the assault. They have the ability to use higher brain function, problem solving. They have a timeline. They have the advantage over their victim of even language skills to direct. This is what I want you to do. I'm telling you what I want you to do. They have memory. They planning. They're able to enact that plan. They have organization of the timeline of the event. They have it all planned. The victim, so the suspect, let me go back. The suspect, his brain is operating in this large frontal lobe, which is the large blue area. The victim's brain is operating on this teeny little yellow area of the brain. The loss of the frontal lobe, that's completely shut down. So hormones take over. All they have is fight, flight, or freeze at this point. So then when you look at the two and you bring in the suspect for interview, for questioning, and you're interviewing the victim, who's going to be able to answer the questions better? Who's going to be able to recite a history better? And this is why sometimes the suspects seem more credible than the victim, because the victim, if you're asking the suspect and the victim the same questions, probing the frontal lobe, the suspect can answer all the questions. The victim can't. So the suspect is going to look more credible. But what you need to do is ask, especially law enforcement and detectives, need to ask the victim the questions that are focusing on the hippocampus. What did you smell? What did you see? What did you hear? That's where the memory is of the assault. So I do have another one, but I think that we're going to be out of time. Basically, who, what, where, why questions are probing the frontal cortex, just the facts, or just a bad idea. It's not the answer that enlightens, but it's the question. Does anyone have any questions? And if we have time, I can go back to that other case study, but I don't want to hold anyone up unnecessarily. Oopsies, I hit something. How much time do we have? Okay. All right. I think we're up on time.
We definitely have plenty of time for questions.
Okay.
It's scheduled till 9.
Oh, well, I can always do, I can keep talking, trust me, but I don't want to hold, I don't want to have a captive audience. I don't want to hold you up.
One of the questions that had come about, it was like, for one, is an assault occurs, the patient's taken to the hospital. What's the sort of time frame now where the patient will be at the hospital to be seen, and then the time frame when they leave, and then when labs are done, and then when it goes to court, and then there's a final outcome?
Oof. Well, so when the patient's brought to the hospital, and I can only speak on behalf of when I worked at GBMC a year ago. The forensic nurse examiners at GBMC, they have an 1 hour time response time. So a patient of sexual assault, strangulation, domestic violence, child abuse, child sex abuse, they should be seen by the forensic nurse within that hour. Then generally a case would take, it could take up to 6 hours for the forensic nurse to get the history, draw labs, get the medications, and collect evidence, and then discharge the patient after the patient's been seen by the ER. So that could take up to 6 hours. Then when the case finally is brought, charges are brought by the state's attorney's office. That really varies on how backed up the state's attorney's office is, but then also, then you get all of the delays by the defense attorneys. Often they need more time. So that could be delayed years. It could be a few years before a case.
The forensic nurse has the first time with the patient for multiple reasons that are quite proper and necessary. When the forensic nurse is done, is that when the detectives start talking to the patient, or does the forensic nurse decide that occurs, or when, or because that would be the next level? Because I mean, in EMS, everyone's told you must report this to the police. You direct. It's not the ER's responsibility as much as it's yours, and they would do that through notifying the dispatch. When does the police now enter the picture to follow? Obviously not before, unless there was a specific life-saving reason, but when's the next, when does that phase occur?
So it depends. So if it's an adult victim of sexual assault, and if she does not want law enforcement involved, then law enforcement cannot be notified if she doesn't want them. If it's a care in custody, if it's a child sexual abuse and it's a care in custody issue, then that's a mandated report. If they're not sure, then I would say transport to GBMC, and then, but generally, it's kind of a variety. It really depends. And I think it probably depends on how the call comes to the 911 call system in the very beginning. So if someone's calling and saying, I've been sexually assaulted, and police are dispatched at that time along with the EMS, or if it's a strangulation, police, then police have already gotten involved. And then if they feel that the victim wants to go ahead and speak with police, speak with detectives, then they'll go ahead and get detectives called. So generally, detectives are notified when the patient's still in the field. But if it's
reported as a rape, for example.
Yeah, if it's a sexual assault and it's an adult, victim and they do not want it reported to police, and they don't want to report, they just want a delayed, what's called a delayed report, where they don't want law enforcement involved, they don't want a police report made, then police should not be called. And it's their right not to report it at that time.
I would think though, if, as again, when the call comes through 911, if somebody called and said, I was just raped, please send me an ambulance, the police will be notified.
Yeah, and then at that time, if the patient declines any involvement with law enforcement, then they can kind of walk away at that point.
Does that make the nurses, I guess, are the liaison for that?
I'm not sure.
Or is that directly with the patient to the police?
I don't understand the question.
In other words, so the patients, you all are brought to the patient for multiple reasons, whether it's labs, evidence gathering, find out what happened. Does the nurse there become the liaison or for the patient, or is that they're just part of the care team?
Part of the care team. So the patient can come to the emergency department. Say EMS brings them in and law enforcement doesn't show up and the patient's brought in, then the forensic nurse will ask them, do you want me to call police? Do you want me to contact police? Do you want to speak with police? And as long as they're not a vulnerable adult or a child under that's falling into care and custody, so we're just going to say it's an adult. And if the nurse can say, do you want me to contact law enforcement? Do you want to report this to police? If they say yes, then the nurse will go ahead and call 911. If they say no, I just want evidence collected, but I don't want to talk to police right now. And there's various reasons. I mean, it could be a family friend who they need time to think about reporting, because there's going to be, a pretty big issue with that. If it's somebody like, say, somebody in college and it's their friend group, somebody sexually assaulted them of their friend group, then they might not want to report that right away. They might really want to kind of talk to their parents or just think it through a little bit more. If it's a spouse who's violent, but they've still been assaulted and they need medical care, but they know if they report it to police and the violence is going to increase, they might not want to report it to police, and they don't have to. So for the at GBMC, you can have police involved and evidence collected, or evidence collected, no law enforcement involved, or no evidence collected, no law enforcement involved, but you can have a medical evaluation by ER physician.
Do you find that the victims, the majority of the time, know the perpetrator?
Yes.
Okay. I'm sure that makes it harder.
And I mean, occasionally there are stranger rapes and serial rapists. So don't discount that at all. We've seen, quite a few. But generally speaking, especially with the child's sexual assaults, it's generally someone who is known to the family. So know who's around your kids.
Okay. That must be much harder to deal with.
It is. All right. Well, thank you for having me this evening. If there aren't any more questions, this kind of dragged me out of retirement a bit, but but I'm happy to be here.
We appreciate you coming tonight. It's a very difficult topic for people. It's definitely an emotional topic. It's not something society wants to deal with or even see.
It's not, and the problem with this topic that I find, and every time I would teach this, especially in person, you can see the people who are reliving things that they went through, realizing that when they think of that event, where their brain goes is where they felt the most fear. And sometimes that's, people have different levels of of trauma in their past. And sometimes that's just really hard. Like I would say the most heartbreaking story was this one. I hope I can even get through this. This woman was crossing the street and she was blind and she had her dog, and somebody ran through the crosswalk and her dog saved her life, and he was killed, and he was a guiding eyes for the blind dog, and she had him his whole life, and her brain kept reliving the same memory over and over, and she couldn't figure out why. And then she was actually a social worker, and she was sitting in one of my lectures, and she was just like, it all makes sense now. I finally figured out why my brain I would have the same memory over and over. And it was like, start there and work through that. But it kind of unlocked that for her. But I thought, I just can't imagine. So I think that's why this topic is more difficult than probably any other, because it hits home, and I think everyone can relate.
That's very, very, very true. Well,
So
thank you very much.
thank you on that happy note.
But it's important.
It is. We always end on a high note. So here's my high note, if I can find it. There's my high note. So we end on a happy note. So go do something fun for yourselves after this, Debbie Downer. But I hope that it was really informational, and I hope that the next time you have someone in your ambulance, even if you think it's a minor incident, if it's stressful or traumatic to them, it's still stressful and traumatic, and they're still going to have the same stress response.
Absolutely. I mean, for one thing, they called the ambulance because obviously they wanted some type of help.
Right. So that's stressful in itself for most people to even dial
Just to
911.
cross that line, that's a very big line for people to cross when they invited strangers to their life to help them out in their moment of need.
It is. So I would say all of those people are stressed to some degree, and that their level of comprehension, maybe their level of even language skills at that time, it's just going to be more difficult for them.
And I agree with you. We make a difference.
Well, and thank you for all that you do, everyone here tonight. Thank you.
Thank you. Thank you for having us.
Certainly.